Welcome all to our special edition of the TB Think Tank webinar series. This session is titled Package of Care for Adults with HIV Who Are Hospitalized with Possible Tuberculosis. A brief introduction of today's presenter. Dr. Leanne Davids completed her undergraduate medical degree at the University of KwaZulu-Natal and had initially considered pursuing a degree in obstetrics and gynecology. After completing her community service, as well as a postgraduate diploma in obstetrics in the same year, she pivoted towards a career in primary health care, having observed the immense strain that the HIV epidemic had placed on the public healthcare system. She has spent roughly 7 years working in primary health care, both in public and private sectors, as well as the private emergency healthcare setting. During this time, she gained a wealth of experience and exposure to infectious diseases, particularly HIV, both in adults and children, and all forms of tuberculosis. She is part of the South African HIV Clinicians Society Expert HIV GP Network and serves as the co-chair of the TB Think Tank Optimizing Treatment Outcomes Task Team. Over to you, Dr. Davids.
Hi, good afternoon, Olwazi. Good afternoon, colleagues, and thank you so much for the opportunity, for the time that you've set aside to attend this call. And yeah, thank you very much to the Secretariat for the opportunity. We were tasked with developing this guideline. Sorry, I'm probably not sharing yet, Olwazi. If somebody can just give me an indication, if you're able to see my slides.
A few seconds.
Yeah.
Yes, we can.
Is that better? Yeah,
Yes.
so thank you, colleagues. So I'm presenting this body of work on the Optimizing Treatment Outcomes Task Team. And we were tasked to develop this guideline entitled A Package of Care for Adults with HIV Who Are Hospitalized with a Possible New Diagnosis of Tuberculosis. And I think it's quite timely that we were given this opportunity the day after we commemorate World AIDS Day. So just a few acknowledgements. Right at the outset, I would like to acknowledge our task team chair, Dr. Marion Loveday, for just the outstanding leadership throughout this process. Just to thank the Secretariat as well for facilitating meetings and inputs. And the other reason I thought it's important to mention all the collaborators right at the outset was just to assure those on the call and everyone else who might read this guideline that we consulted widely with experts in different provinces. We had 5 infectious diseases physicians, research clinicians, as well as respected researchers. And really, we gave everyone within the think tank an opportunity to participate in this body of work. The other reason we consulted widely was we thought it was important to account for resource availability in different provinces, acknowledging that these are not the same throughout the country. And by doing so, we also really hope that we've done our best to make sure that when this guideline has been completed, that it would receive widespread adoption. Now, what was the purpose? At the think tank face-to-face meeting last year, a concern of high pre-hospital and in-hospital mortality due to TB was raised. We were then tasked with developing a guideline to see how best we could approach this concern. We've been through roughly 20 iterations of this document. Admittedly, it's taken longer than we had anticipated, but very proud to announce that it has now finally been improved by the Think Tank Exco, and we are just waiting sign-off by the National Department of Health. Now, the purpose of this guideline was to address the diagnostic workup and management strategies for persons living with HIV who require admission with a possible new diagnosis of TB. Now, persons with HIV presenting to the emergency room with a possible diagnosis of TB is a very common scenario, hence our decision to collate the latest research developments and to try and formulate this guideline. Importantly, this is also not aimed at individuals who were started on treatment and then lost to follow-up, but specifically for persons with HIV who are presenting to the emergency unit with a possible new diagnosis of TB. So we aim to develop a guideline that is pragmatic, evidence-based, current, and that would equip clinicians staffing emergency units, and these are usually junior doctors, interns, commserves in peripheral settings, to help them to make the diagnosis of TB both confidently, timely, and responsibly. I think right at the outset, I want to say that we are by no means suggesting that this guideline is the panacea to addressing early in-hospital or all early in-hospital mortality due to TB, but I think this is a very useful guide and reference tool. We also acknowledge that there are countless factors in the pre-hospital setting that has an impact on early in-hospital mortality due to TB, as well as numerous health systems challenges, but this, however, was not the focus of this particular task. And this discussion largely falls outside of the ambit of what it is that we set out to do. Importantly, as well, we aligned this guideline with the South African National Department of Health guidelines, the World Health Organization guidelines, as well as guidelines from the Southern African HIV Clinician Society. We are aware and really excited about newer diagnostics and specifically non-sputum-based diagnostics that the WHO has called for. You might note that we have not included those in this particular guideline, and the reason for that is that we only approved only included diagnostics that have been approved by the World Health Organization and the National Department of Health. Additionally, what we also hope this guideline would do is to enable clinicians to systematically look for an alternative diagnosis if TB has been excluded. Just some background. TB is the leading cause of hospitalization and early in-hospital mortality in persons living with HIV. And mortality in persons living with HIV is unacceptably high. And we note that a delayed diagnosis is a major contributor. Even a delay in diagnosis of even a few days post-hospital hospitalization may result in higher mortality. Those of you who have read the 2024 Global TB Report would have seen these numbers, that in 2023, 10.8 million people fell ill with TB globally, and TB was responsible for 1.2 million deaths. But this is, followed by, we saw a similar decline in the numbers in 2023, as well as 2022, which is encouraging. What we also learned from this report is that the 2024 report is that 55% of the incident cases were men and 33% were women. And this is in keeping with what we saw in the South African TB prevalence survey, which we saw that men have a 1.6 times higher chance of developing TB than women. It does, however, appear that TB has now once again become the leading cause of death due to an infectious agent globally, after having been surpassed by COVID in the 3 years prior to that. We do know that the African and European regions are making some progress towards the 2025 NTB goals. And what we also know is that one of the NTB targets is a 95% reduction in TB deaths in 2035 compared to 2015. But early in-hospital mortality due to tuberculosis undermines this target. We do, however, think if we have guidelines to try and curb early in-hospital mortality, this will be a significant step in the right direction. Just turning our attention to the South African TB stats, our incidence currently sitting around 300 to 499 per 100,000. And I think I would be amiss if I don't just mention something about the HIV statistics, considering that we are commemorating World AIDS Day. We know that from the 6th South African National HIV Prevalence Survey that was released last year. I'm sure you'll hear a bit more about that in other webinars, similar webinars today. The HIV prevalence currently in South Africa is sitting at 12.7%, and that means that 7.5 million people living in South Africa older than 15 years are living with HIV. Encouragingly, this is down from 14% in 2017. We also know that UNAIDS reported in 2023 that there are 39.9 million people living with HIV globally. And we are seeing that we're making progress towards the UNAIDS 95 targets. This is from World Maps, just to illustrate the stats that I was speaking about in the previous slides. And it shows the territory size proportion of all people living with HIV between the ages of 15 and 49 worldwide. And we see this disturbing, if I may call it that, ballooning effect on the African continent. And we see a similar trend with tuberculosis, both in Africa, parts of Asia, India, China, and Eastern Europe. Now, what is in this document? We have a background section with some basic epidemiology, similar to what I discussed previously. We have a suggested initial management approach to follow on presentation to the emergency center. We have some guidance on when to consider empiric TB treatment. There's a suggested algorithm. We have a management approach to follow if the initial TB workup is negative. We have some guidance on monitoring post-treatment initiations. There's a bit of emphasis on drug-drug interactions and useful reference tools, as well as tables summarizing the performance of the various TB diagnostics. Now, I must just at the outset mention that I'm cognizant that the audience today is probably largely quite experienced clinicians, and most, if not all, of what I will be mentioning today is probably what you're already teaching and practicing in your various workplaces. This document, however, is largely for junior clinicians, often in peripheral settings and often in settings where they don't have a lot of support. So there's really no substitute for good clinical assessment. So doing a basic symptom screen, on history taking special note of antiretroviral treatment exposure, previous TB treatment and prophylaxis. To assess for danger signs, we know that danger signs are not unique to TB, but they are common. So that is a respiratory rate of greater than 30 breaths per minute, a heart rate of greater than 120 beats per minute, an inability to walk unaided, a temperature of greater than 39 degrees Celsius, confusion or decreased level of consciousness. Those are the WHO danger signs. If the patient's HIV status is not known, it's important to do an urgent and rapid HIV test, accompanied by the appropriate counseling, of course. And this is really the next two bullets are the messages that we want to drive home. Number one is that a urine lamp TB test should be done in all patients with HIV, persons with HIV rather, admitted to a hospital ward. And this is irrespective of the CD4 count or reason for the admission to the hospital ward. And then secondly, a sputum TB nucleic acid amplification test, for example, a Gene Expert Ultra, should definitely be obtained. Now we know obtaining sputum samples could be difficult in sick patients living with HIV, and so an induced sputum should be considered, provided the necessary infection control requirements are met. And then a chest X-ray to evaluate for infiltrates, lymphadenopathy, pleural or pericardial effusions. And even if the chest X-ray is normal or considered normal, we advise that you continue with the management approach to look for possible diagnosis of TB or an alternative diagnosis. Then supportive care. This needs to be instituted, for example, antipyretics, hydration. If a bacterial pneumonia is clinically diagnosed, a broad spectrum beta-lactam such as ceftriaxone is the preferred antibiotic. Then also cotrimoxazole, if that is clinically indicated, but paying attention to possible contraindications. For example, you need to be cautious in patients with a folic acid deficiency, severe renal or hepatic impairment, serious hematological disorders, and in geriatric patients. And then all patients hospitalized should be started on thromboprophylaxis unless otherwise indicated. Some blood tests that should be considered on initial assessment is a baseline renal function test, a CRAG, especially if the CD4 count is less than 100, a liver function test, although this is not routinely indicated, and viral load and a CD4 count if the patient is on antiretroviral treatment, and if not an antiretroviral treatment, a CD4 count only. And just to take note as well that patients with HIV admitted to hospital with possible TB frequently have disseminated disease, and they often present with non-specific signs and symptoms and have very high early mortality. Some further considerations. So even though TB is very common in the subgroup of patients, there could possibly be many concurrent opportunistic infections with higher fatality, which need to be treated urgently. Specifically, cryptococcal meningitis and PJP. PJP, fortunately, we're seeing much less of now in the antiretroviral treatment era. However, cryptococcal meningitis is an important consideration, especially because it has a very high associated mortality. And then just some suggestions for when to consider empiric TB treatment. In the following cases, this should be considered patients presenting with a compatible or have compatible presenting signs and symptoms, suggestive radiological features, or the following, suggestive of extrapulmonary TB, for example, large peripheral nodes greater than or equal to 3 centimeters in diameter, a miliary picture on chest X-ray, an exudative lymphocyte predominant pleural effusion, a pericardial effusion, or a lymphocyte predominant picture on CSF, provided that cryptococcal meningitis has been excluded. But just really importantly to highlight to colleagues that pursuing a microbiological diagnosis is important. But just turning our attention back to empiric TB treatment again. So none of the features that have been suggested are specific, but in most cases, TB is the most likely diagnosis. Also, if the patient has danger signs, the decision to initiate TB treatment may be expedited. However, other conditions can also present with danger signs. And just an algorithm that we suggest, and this is really just to summarize what I mentioned previously, is a urine LAM, a sputum gene expert ultra, a chest X-ray, some baseline bloods that can be considered are an FBC, renal function test, liver function test if the patient's jaundice, serum CRAG if the CD4 count is less than 100, and a CD4 count and viral load if clinically indicated. Other clinical samples that could support a diagnosis of TB should also be sent to the laboratory. And then, as mentioned prior, the indications for empiric TB treatment is compatible presenting symptoms, compatible radiological features, or features suggestive of extrapulmonary TB. And then the last block, really, we had a bit of back and forth about this one. We thought perhaps it would be too pedantic to include that in the algorithm. But in reality, a lot of similar issues here fall through the cracks. Blood results or other samples being taken but not delivered to the laboratory, getting to the laboratory but the test not being done, or results just not being followed up. And so it's just important to highlight to colleagues to follow up on, to review the blood results or any other samples really, and especially to review the decision for empiric TB treatment. So what to do if the initial TB workup is negative? This, of course, is directed by the clinical picture as well as the resource availability. And as I mentioned in a prior slide, this guideline also aims to equip clinicians to systematically look for an alternative diagnosis if the initial TB workup is negative. So a couple of things that you could do is a sputum TB culture and a drug susceptibility test if the gene expert is negative and if there continues to be a clinical suspicion of TB. If lymphadenopathy is present, especially if there is a lymph node greater than or equal to 3 centimeters in diameter, an FNA should be done. On the FNA, you can request a gene expert, TB culture and sensitivity, and the sample can be placed in a TB transport medium if that is available. If not, just a sterile tube will do as well. On abdominal ultrasound, if an abdominal ultrasound is indicated, what you should be looking for is abdominal lymphadenopathy, ascites, micro or macro abscesses in the liver or the spleen. But also other conditions can also appear similarly. For example, a lymphoma can have very similar features. Bloods can be sent off for TB blood culture. And if there's a pleural or cytic fluid present, TB gene expert can be done, as well as a TB culture and sensitivity. Now, both the diagnostic sensitivity of TB gene expert and culture are probably imperfect in serous fluids, but these should still be requested. In the case of an exudative pleural effusion, if the suspicion of TB is high and the pleural fluid of TB gene expert is negative, consider a pleural biopsy and start empiric TB treatment. We also acknowledge that a pleural biopsy may at best be out of reach for most people working in a peripheral setting. In the case of pleural or pericardial fluid, an ADA of greater than 30 units per liter with a lymphocyte preponderance is suggestive of TB or malignancy, while an ADA of greater than 30 units per liter with a neutrophil preponderance is suggestive of bacterial infection. Pleural effusions in TB can be of any size really, but generally if you have more than half of the lung volume, this is highly likely to be due to TB. In the case of acidic fluid, if an ADA is greater than 30 units per liter, this is also suggestive of TB. And what we've done in this particular document is that we have aligned the reference ranges with that of the NHLS ranges. So just a few notes on possible TB pericarditis and when, when this should be considered. If there are clinical signs and symptoms of moderate or large compressive pericardial effusions, in addition to compatible TB symptoms, and a pericardial effusion confirmed by ultrasound, a safe and diagnostic or therapeutic ultrasound-guided pericardiocentesis should be done, and the patient should be commenced on TB treatment. And this is to confirm the following. Number one, to confirm the TB diagnosis and drug sensitivities. Secondly, to rule out alternative treatable conditions. Thirdly, to relieve cardiac compression and tamponade. And lastly, to reduce future constrictive pericarditis. Just to caution those on the call that if ultrasound-guided pericardiocentesis cannot be performed, the patient should preferably be transferred to a facility where this can be done, as complications of blind pericardiocentesis are high. Now, there's an entity called bystander pericardial effusions. These are small and asymptomatic. They're often found incidentally on ultrasound in patients with constitutional symptoms and no evidence of TB elsewhere. This should not be used as a confirmation of TB pericarditis. Pericardiocentesis of such effusions are associated with high complication rates and carry a very low diagnostic yield for TB diagnosis, and therefore this is discouraged. In patients with focal backache, we recommend conducting spinal imaging, especially if lower limb neurological deficits are present. Now, I mentioned before that PJP is fortunately rare in the antiretroviral treatment era, but it's still a very important consideration. And if you miss diagnosis of PJP, morbidity in those patients are exceptionally high. Some of the features are dry cough, fever, a progressive shortness of breath, respiratory rate of greater than 30 breaths per minute, desaturation, and a chest X-ray showing interstitial ground glass infiltrates. A viral pneumonia could also be a consideration. For example, varicella zoster virus, influenza, and COVID. So what we've attempted here is to enable clinicians to have an approach that is both wide and systematic to look for an alternative diagnosis should TB be excluded. Some differential diagnoses that could be considered. Number one, in our setting, very important, is that of drug-resistant tuberculosis. So it's very important to follow up the drug, the culture result, as well as the DST rather, especially if the gene expert was negative. Other considerations are a lymphoma, Kaposi sarcoma, endemic fungal infections, non-tuberculous mycobacterial infections. A true cut or excision biopsy should be considered to exclude a lymphoma. If the patient has CNS signs, some of the considerations are TB meningitis, tuberculomas, toxo, cryptococcomas, and cryptococcal meningitis, just keeping in mind that cryptococcal meningitis has high associated fatality. In persons with gastroenteritis, a non-tuberculous mycobacterial infection is a consideration, Isospora, Giardia, Salmonella, CMV, as well as Shigella. And in patients with thrombocytopenia and anemia, some of the considerations are malaria, lymphoma, immune thrombocytopenia, thrombotic thrombocytopenic purpura, as well as hemolytic uremic syndrome, amongst others. So then, regarding the monitoring of patients after initiating TB treatment, and here I really want to mention that we focusing specifically after initiating treatment on drug susceptibility, on treatment for drug-susceptible TB. This work was done, the study that I highlight here is work done at a district hospital in the Western Cape, specifically just talking about anti-TB treatment-associated drug-induced liver injury, and this has significant morbidity and mortality, specifically in persons living with HIV. From the study, we saw that there was a 35% mortality at 3 months, and the median time to death is 11 days. So you can tell there's really not a lot of time for you to make the diagnosis and to intervene in order to limit associated morbidity and mortality. The pathogenic mechanisms and management are complex, and these are both related. Drug-induced liver injury is related to both medication as well as genetic factors. Now, TB treatment-associated drug-induced liver injury, that is a discussion, a topic all on its own. And we have aligned our guidance with that published by the Southern African HIV Clinician Society that was published earlier on this year, correct? And I would really encourage colleagues to read this article. And if there are some of the collaborators who worked on this paper or are perhaps on the call, please feel free to participate during the discussion after my presentation. But this is really, really amazing guidance. It speaks a bit about the mechanisms of injury, re-challenge regimens, severity assessment, as well as admission criteria. Now, in the ideal setting, you would want to admit all of these patients. I've spent a number of years working in peripheral settings, and more often than not, it was really, really difficult to admit patients with drug-induced liver injury. And so it's really important to equip colleagues who work in peripheral settings with these particular guidelines so that they can manage patients both confidently and safely in a peripheral setting. Just a couple of points from the guidelines is that baseline LFTs are often done, but are not a requirement in all patients. And they're recommended for persons at risk of TB treatment-associated drug-induced liver injury. Also, that abnormal liver function tests are not a contraindication for TB treatment. If there's a baseline abnormal ALT or total bilirubin, monitoring the patient weekly until he or she is stable or improved. And then we know the common offenders are isoniazid, rifampicin, pyrazinamide. Moxie and levo, they can also be associated, can also cause a DILI, but they usually present with a mild and asymptomatic rise in transaminases. But really, like I said earlier on, this is a topic all on its own. So just to advise colleagues to please take some time to read this article. Just further on, just some basic points as well as to review the medication list and common drug-drug interactions. What we have mentioned in this guideline is the commonly used agents, dolutegravir, corticosteroids, warfarin, anticonvulsants, and then a newer anticoagulant, which is rivaroxaban. Rivaroxaban is affected by potent CYP inhibitors like rifampicin. So co-administration of rivaroxaban and rifampicin will significantly decrease the plasma concentration of rivaroxaban, and therefore co-administration is advised against. I must add, though, that the literature on guidance on the co-administration of rivaroxaban and TB treatment, it's really scant. So if there is anyone on the call perhaps with more insights in this regard, also please feel free to weigh in on the discussion afterwards. And also the drugs that we've mentioned that could present with common drug-drug interactions, that it's not an exhaustive list. There are very many others. Then also, I just want to mention something about the HIV clinician, the National HIV and TB Healthcare Worker Hotline. They have come to my rescue countless amounts of times in my career. You can call them anytime, Monday to Friday, between 8:30 and 4:30. There's a hotline that you can dial toll-free. You can send them a please call me. They are incredibly responsive, and the advice has always been really, really good. Alternatively, you can download the app either via the Google Play Store or via the iStore. What we also offer in this particular guideline is a summary table of diagnostic tests. What we offer is aligned with an article that was published very recently in the New England Journal of Medicine, which is a really fascinating piece of work on HIV-associated TB and the most recent developments in this particular field. So what we've done is we've collated all the commonly used diagnostics, and we've compared the various diagnostics that could be available, some special notes, and then we also make mention of the performance of the different diagnostics. So I won't go through the entire table word by word, but just to highlight a couple of useful points. So if you can obtain a sputum sample, either easily or by the means of induced sputums, all patients, like I said, need to have a gene expert ultra done. Importantly, to follow up with a TB culture and sensitivity, because we know that if the expert ultra is lower, it doesn't mean that TB necessarily is excluded, given the sensitivity of 87.6% and the specificity of 92.8%. If you can obtain if TB meningitis is suspected, a tap should be done in all patients with suspected TB meningitis. Gene expert should be requested, as well as TB culture and sensitivity. Additionally, you should be doing a protein, glucose, cell count, cryptococcal antigen, gram stain, and bacterial culture. And then just some notes on the performance of the various diagnostic tests, both the Gene Expert Ultra, which has a sensitivity of 89.4% and specificity of 91.2%. And you'll see what we've done there is that is measured relative to the gold standard, which is a culture. If you obtain a serous fluid, importantly as well to do an expert as well as a culture. And as I mentioned earlier on, if an ADA greater than 30 is likely due to TB, and exudate, if it's rich in exudates and lymphocytes greater than 300, we can also do a bacterial MCNS. And then the sensitivity of the gene expert in serous fluid, it's low, it's 85%. Specificity is at 87%. And there's also, we've just made a note to say that relative to effusion fluid TB culture, which is an imperfect gold standard. Mycobacterial TB culture also can be requested. And then commonly in our setting as well is TB lymphadenitis. So if you have a lymph node aspirate, a gene expert should be requested, as well as a TB culture and drug susceptibility. The expert ultra doesn't perform all that well, only has a sensitivity of 70%, but a really good specificity of 100%. And then lastly, on urine LAM. This performs best in hospital settings and in patients with low CD4 counts. False positive tests occur with disseminated non-tuberculous mycobacterial infections, and the urine LAM unfortunately doesn't provide any information on rifampicin susceptibility. Sensitivity of the urine LAM is low, but it does have a specificity of 91%. So the urine LAM is a very useful tool in hospitalized sick HIV positive patients, especially with a very low CD4 count. I think I've just come to about the end of my slides. Just to thank the audience for your time and your attention. Thank the Secretariat for the opportunity, and then like a depth of gratitude to the collaborators. This is not my work, but it's really a product of a great team of experts that work together. Thank you, Nolwazi.
Thank you so much, Dr. Davids, for that presentation. Now, colleagues, it is time for our question and answer session. So if you have any question or comment, please do raise your hand, or alternatively, you may also enter any comments under the Q&A tab. So any questions or comments for our presenter today? Thank you. Dr. Subrayan, you may go ahead.
Thanks, Nolwazi and Leanne. Thank you so much for an excellent presentation. I'm just thinking about all these extrapulmonary samples that we're recommending Gene Expert, and I know that the country as a whole and NHLS has been kind of moving towards, not just the single supplier of the Gene Expert platform, but we have already got BD-Max and Cobas. And this is not necessarily a question directed to you, but I don't know if we've got anyone from the laboratory here. Or maybe Leanne, you know this, but I was wondering, is it exclusively for the Gene Expert platform that we require, the extrapulmonary samples, or is there some data around the use of the other platforms that I mentioned that detect resistance not just to rifampicin but INH as well? And I also completely understand if you don't have this information. Sorry, I'm just thinking because I do know that we are transitioning out, from exclusively the Gene Expert platform. Thanks.
So, admittedly, Priya, I don't know if any of the other collaborators are on the call and maybe want to weigh in on the discussion. But I'll try. So what we've done is we've said broadly a nucleic acid amplification test, and then we've mentioned Gene Expert Ultra, specifically because we wanted to streamline this with what has already been approved. Now, I'm not too sure whether the other tests that you've mentioned have been approved by national or not. I'm not sure, but if they have, then at this stage, Priya, for the purposes of advancing this guideline, I'm not sure if we will backtrack, and change the guideline. But going forward, the idea is really to have different iterations as as data becomes available, and also as different diagnostics are approved by both WHO as well as locally. Charlotte, I see your hands up, so please go ahead.
Hi there. I just wanted to add to what you were saying. Thank you very much, Leanne, and very, very good question. So we tried intentionally to keep this guideline sort of open to new data about nucleic amplification tests and new testing platforms becoming available. And I think the table that Leanne showed was simply summarizing the most current and up-to-date sort of diagnostic data on the tests that we have data on. So we're very aware that there will be new diagnostic platforms becoming available and that there will be new data to add, and different tests will be available likely in different places. So we want to just encourage people to use nucleic amplification platforms according to what they have available in their settings. I hope this answers the question somewhat.
Yeah, no, sorry, it does. And Leanne, just, to go back. So yes, it is a test that has been approved. It's already being rolled out. And at the moment, we're receiving results that indicate, that it hasn't gone through the Gene Expert platform, but the other platforms. And we're getting results that are either sensitive or resistant to INH as well. So it is currently being implemented, and it's happening in a phased manner, but the idea is to, have, and I'm not sure exactly where, but I think the high volume sites are to have this, the BD-Max and then the Cobas, and I think only 30% coverage ultimately will be Gene Expert. But yeah, no, thanks. And, sorry, I do realize that was a bit of an unfair question, but I wasn't so sure what the evidence was saying around, extrapulmonary samples for these two new additional tests. Thanks.
Thanks, Priya.
Thank you so much, Prof. and Dr. Subrian. I do see comments here under the chat. Dr. Dlamini-Miti, are you able to unmute and perhaps share with us your comments, or alternatively, Pedro da Silva? If you're able to unmute and perhaps share with us your comments.
Maybe I can just read it, if Pedro, because it would be really helpful. Dr. Da Silva, you've answered it in the chat. So what Nomatandazo Dlamini-Miti is suggesting is that last I heard, other TB knots were not validated for non-pulmonary samples. And then Dr. Professor De Silva said the following: currently, the moderate complexity platforms such as BD or Roche Cobas are not endorsed for extrapulmonary TB specimen types. Extrapulmonary TB specimen types will continue to be processed by the Expert Ultra assay. The BD and Roche Cobas platforms, where available, are used for specimens of respiratory origin. So, Priya, I hope that also sort of partially answers, speaks to the question that you asked. I'm not sure, Professor Dr. De Silva, you're more than welcome to weigh in on the discussion.
I do see, Dr. Davis, that De Silva says that they're in a noisy environment and aren't able to talk. But thanks for weighing in there. Any other comments or questions for our presenter today? And also in the meantime, whilst we get a question, okay, go ahead.
I just wanted to bring up one test that we did not include in this document, but that I'm hoping would play a more important role in this specific patient group in the future. And I think there's a lot of sort of evidence building around doing a urine gene expert test. So we, in our research group, really focus on patients who are hospitalized at the time that they are diagnosed with TB, who we increasingly recognize as an acutely ill population, that really needs sort of emergency management. And hopefully this document will contribute to improved and streamlined management and diagnostics. And I'm sure all the clinicians on this call would be familiar with doing urine experts, which is not currently, I think, endorsed or routinely done. But just within our research setting, we've been using it extensively, and that definitely gives the best yield in patients who are presenting to hospital with advanced HIV disease and who you suspect might have disseminated TB, where it's always very difficult to get sputum samples. Just in our research setting, we've already had very high yield with urine expert, but it still needs to be fully endorsed by the Department of Health, and it isn't currently, so that's why we haven't included it in this document. But I just wanted to put it up for discussion if anybody wanted to discuss this.
Thank you, Charlotte. Any hands at response to that or any other comment? May go ahead, Ribka.
One question I had about urine is, my understanding is it has to be centrifuged, and also CSF has much better yield if this larger volume specimen is centrifuged. Is that something that could, for the lab folks in the environment, and sorry, Pedro, to put you on the spot when you can't talk, but is that something that is feasible to implement at a larger scale?
Thank you, Ribka. Whilst we await Pedro's response, perhaps as well, if anyone else on the call can also weigh in whilst we wait for Pedro to type, as they aren't able to talk. And in the meantime, I just would like to remind everyone in attendance that if you'd like to see yourself on this platform, especially in the coming year, please do email myself at ngozi@tbthinktank.org or anyone else within the TB Think Tank Secretariat. Comments, questions, or any remarks from the other colleagues that also worked on the document?
And always, yeah, I think the audience is a bit quiet. So, you know, this was obviously our first attempt at drafting such a guideline. As you know, as further research becomes available, this will be updated and really just to extend an invitation to other colleagues who are willing to participate in this work in the future. If we send out an invitation to please feel very free to assist us. I see Pedro has answered in the chat. Was he? So let me just read this. So regarding urine, performance and data largely in such co-infected with HIV, much discussion around this and fears that if endorsed, urine would become the preferred specimen. Open brackets due to ease of collection, close brackets, and patients not necessarily adequately investigated. Yeah. Yeah, I think that's a good point. I mean, urine's obviously so there's two sides to this, right? Number one, if you have very sick patients with HIV, we know it's often difficult to obtain a sputum sample, right? And a urine sample you have to pass urine at some point, but the reality is that we don't want clinicians to stop at a urine sample, and I think that is perhaps what Professor De Silva is alluding to, is that if we stop at the urine sample and don't progress beyond that and don't look for you know, either confirmatory TB diagnosis or an alternative diagnosis.
Thank you for that, Dr. Davids. I think in the absence of any questions or comments currently, perhaps we can close the session, or rather end the session.
Sure.
Dr. Davids?
Yeah, that's fine.
Okay. I just would like to thank everyone for attending, and thank you especially to our presenter and your colleagues. And as a TB Think Tank Secretariat, we wish you a restful and refreshing break until next year. Bye.
Thank you, Noah.
Thank you.
Thanks, colleagues.
Thank you.
Bye. Bye.
Bye.
Nawasi, just quickly, sorry, I can still see we are live. How do we cut off that? Oh, but you're on mute.
Sorry, thanks for that. I was saying I will end the meeting, then perhaps we can jump